you have Madam Nachia, the founder of our organization, Sugar Shah, and Adas. I will be around. You can ask your questions on HR development, and I have a panel which will answer.
It's most of the time it is appears to be very easy to say that motivate them, cultivate them or construct them, etc. But whenever we fail, when we fail on this ground, then we formulate another policy, something like a contractual staff or a temporary staff or a daily wages staff. And most of the time in class 3 and class 4, our experience is that they work far better than the other group. What is the experience of experts?
I think the question is the in-house staff works much less than the contractor people. I think the basic is if you're your own servant, if he goes to the neighbor and if they give 100 rupees, he will respect that 100 rupees better than your monthly salary. The tendency is a little different. But I strongly feel and experience in our own institutions, contract job is only a temporary thing, where everything is not shared with him. He comes and does the work. But suppose if the person is vomits in the hospital, you have to wait for the contractor or a housekeeper or anything. Personally, having a in-house employee who is good in housekeeping or catering or Adobe, all those things, with the shared vision, what Dr. Krishnadas mentioned, I think it has not penetrated into your brain. I wanted to do the best. I want to do more cataract surgery. You should talk to the cleaner. Let us do clean well so that we can achieve 10,000. That leader has to inoculate that vision to everyone and get the loyalty of the people. That loyalty you can get only from your own employee, but depends on the leader only. If the leader is not good, you cannot expect the people to be good. That is the lesson we have learned today. And that is the success we Aravind has. It's not education matters, it's the loyalty and the aim of, I think today morning I missed that. I was in the government for about almost 14 years. So any good leader, wherever he is, he can get things done better.
Thank you, madam.
Yeah.
Actually, the clip which was missed is from Lage Raho Munna Bhai. It is the sweeper of the Lage Raho Munna Bhai, and what happened. Of course, it's a filmy thing, but it certainly has a message, I think.
Yeah, actually, to have better employees having high values, that depends upon how you have been brought up in moral education. But generally what is practical is that they should have a good salary structure, permanency of job and good progression to progress in the career. How that is ensured in your setup? Like, is their salary structure similar to what government employees are getting? And do they have the threat of losing a job for small mistakes and whatever? Like, if they are permanent, then they feel that they can progress, and then they will naturally invest more time in that.
The question was the threat of losing a job. Exactly. Second is, yeah. We do ensure some reasonably good salary structure and definitely a career growth for all levels of employees, especially for doctors and our mid-level ophthalmic personnel. But coming to the security which we are talking about, it definitely if the employee errs on the disciplinary side, we don't hesitate to sacrifice the employee, and we make them known that even any breach of moral values or discipline, we do not tolerate. But how do we ensure that the employees become engaged is, for those who stay longer with us, we do ensure there is a definite career path development for them. And we are also going on expanding and increasing our scale of work. Also ensures that most of our doctors and MLOPs, they get enough opportunities for progression in their career.
And just as an aside, in the corporate parlance, there is a dictum because there the salary would not be the issue, especially in a high-end corporate sector, but the migration is very large. If you look at an IT industry or other type of this thing, people move every 2 or 3 years from organization. The corporate dictum is people do not leave a job or an organization. They leave a bad manager. So one of the measures of judging, it's not applicable to this, just for this thing, one of the method which a person is judged is how many of your people have left the organization would be a negative indication of the manager's ability. Just as I said, the converse of it is a good manager retains people.
Actually, I understood that the MLOP has a good career path while the person is in the institution. And by and large, they're all young girls who might get married and move. Suppose they were to leave Aravind. What happens? Do they get jobs easily? I'm sure the name is a huge thing, but they have very specific tasks that they're trained for. So can they then be absorbed into the other systems?
You said there is the name Aravind, the trained staff is adequate, and our experience has been that when they cannot be engaged in our own system, they are kind of encouraged to move into centers where they'll be utilized properly. Like there are many centers who would want to take them because they're good in the operation theater or they're very good refractionists whatsoever. So it's not that they remain at home. Most of these girls, once married, move out from the centers where Aravind is positioned, would get good jobs. In fact, there's a little amount of people being like poaching. I didn't want to use that word, but then I think it's appropriate. There's a lot of poaching happening too. And I wouldn't exactly say that it reflects on the managers too, because sometimes the poaching, as Madam was mentioning, it happens because you get a little more in some other center and it suits you better in many ways, or people who would like to compromise a bit on their culture and values probably would want to move away. So most of these MLOPs are positioned in other hospitals too.
I just want to share one incident where poaching. You get the best girl from us, one of the best girl, best leader, goes to another organization. The girl alone is alone there. There is no environment, there is no good leadership, there is no work culture. So she will not be able to give the best to them. So totally both the parties become sad. So that is also dangerous. And one example, one of our housekeeper who does not know anything about ophthalmology, of course they know it, but the basic housekeeper went and administered one hospital in one of the Gulf country. What I'm trying to say is she had 70% of work culture, shared vision, leadership, all those things in housekeeping. She just added few administrative knowledge. She became a leader. So knowledge is not needed that much. The attitude, that's again I'm going on telling you. In our institution, the catering girl, the housekeeper, the operation theater girl get the same salary. Their basic education is same. May not be possible in a government sector. So what I'm trying to say, even you can make us cleaner as a leader. You can make a ward boy or a ordinary A&M nurse into a leader. Sometimes we are missing them. You are going on looking for a nursing superintendent. You're going on looking for a gold medalist. You're going on looking for a smart looking girl. Please think about an ordinary person who can build and who can be loyal to you and who can enhance your work.
Union.
We don't have a union, fortunately, and our environment makes a big change. You go to the temple, you won't talk ill there. You'll come out and talk. You won't do something bad there. You'll come out and do. So creating an environment, it's hard in a government sector. And I worked in the government for almost, that years, and where Dr. Venkatsamy was the chief, we never had union those days. Why unions have come now? I strongly feel the leaders have not dealt them correctly. So today we are almost, including our vision centers, we have 60 centers. We don't have it, and we don't allow the employee to think. We have to be very clean, very transparent in our system. The one thing, we have to trust them and they have to trust us. Don't try to do anything against their thing. And it's a bit, employee is our partner, not our employee. So if we consider them as an employee partner, then without them we can't thrive. Without us, they have all the opportunities. So we have to really take them along with us. Fortunately, we don't have a union, and it will not make people to think on those lines. That is one great advantage between our institution and similar Eyecare institution, rest of the place. They have union. Another secret for not having a union is that leader must not go through the supervisors to the last cleaner. They must go, for example, now Dr. Shidas is in charge. When I was holding that post, I know the name of the last cleaner and when her daughter got married. You know, that depth, not that it's not a big job, that transparency and care for your employee will give you a very good result. Because union and all comes only with frustrations, only when they don't trust the leader.
The first port of call for an employee with a problem should be his supervisor and within the organization. When that is not available, he seeks solace elsewhere. Just to supplement and add to that, that is the requirement. And then you see, day before yesterday, you were not here. Friday, I was here. Friday evening, every first Friday or second Friday, they have a thing called Melody Friday. It's a cultural get-together where the counseling MLOP sings and the consultant ophthalmologist sings and somebody else makes, and their children come and take part. Various activities like that bond them well together. It is an issue. It's not that it's not an issue. I don't want to get into it because I worked in West Bengal in the industry and in the railways in the days when Gerao was a very normal thing, and they also judge the person, how fair you are, how honest you are, how concerned you are, how consistent you are. The moment you play amongst the employees, then it becomes, I'm not saying you, but what I'm saying. So it makes a difference. So there's a lot starts from the top and goes down. Yes, sir.
I feel spiritual undercurrent,
Yeah.
the spiritual undercurrent, which may be there right in this institution or for that matter at CMC Vellore, where the founder or for that matter who has established the institution has given an ideal, is given a higher aim, and all the employees are carrying forward. They share that vision of the founder institution. That plays a role. That is to some extent not possible in the government sector because we do not have. At the local level, some of the people can start it. But I feel in the success of this institution and for that matter, many of the other non-governmental organizations, a spiritual undercurrent does play a role.
I was government 25 years, sir. And I know of a number of my colleagues who had problem, who had no problem. So I don't know the formula. The formula possibly is how focused and how purposeful you are. And one point which Dr. Nachiar made, if I was in charge of a diesel loco shed, I knew the name of the last employee. And for example, one employee got burnt in the diesel locomotive because of a fire. And night 1 o'clock or so, he was taken to the hospital. I was there and stayed there till all the saline and whatever else has to be done, etc. I came home. Next morning, the union came to me. Yesterday, one guy got him burnt, and what have you done about it? I said, where were you last? In presence of the workman, I asked him, where were you at 1 o'clock last night? I was there. Where were you? And that was it. So there's no formula for it. I think you have to grow with it. But fairness, consistency, uniformity in dealing with people, understanding and giving them a listening ear blunts a lot of the unions. They play on your weakness, not on their strength. Anything else, sir? while of course you would have seen Usha's thing, that they have 1:5 and all that, I think in this session you should reflect on how to, more on how to get the best of the people you have, and of course certainly how to get more, but certainly the scope for getting more from the people you have. I think so. It's just a point of reflection. There cannot be a prescription on it. Any other questions? Yes, sir.
Training courses also, including doctors. As the gentleman from CIPS referred to, did you face any problem of training a doctor and the patient refusing to be getting operated by a trainee surgeon? Personally, I feel we will not even let our wristwatch to be repaired by any apprentice mechanic. So it's a question of eye and a body. Nobody will allow if he learns that the person treating us is a training person or he is at the verge of learning. I would like to share here that in Medical College, Raipur, we are teaching our postgraduates along with the senior surgeons, and we give surgery stepwise. One step in one case, and then no patient objects to it. So what is your experience here at Madurai?
Yeah, I think the way you mentioned, stepwise surgical training is what is being done here also. We monitor every step. As we start off training any doctor or a paramedical for that matter too, we would start off initially monitoring the every step, and then we would allow them to do independently but being monitored by a senior surgeon, and then we would let them to perform later. This happens for MLOPs too.
In fact,
Certainly, probably you have stopped giving hands-on for cornea fellows for 2 months if they come. I understand this was communicated from Government of India to me. We wanted to send one assistant professor for cornea fellowship for 2 months, the short training. So it was communicated that no hands-on will be given.
No, sir,
So
did
you have any problem in that? Previously you used to give.
You need a stipulated time for engaging them into surgeries. They need to know the basics, and then there needs to be there needs to be a time frame for which we can train people also. They cannot just come and start off training. They need to go through a certain orientation process, and then they'll have to go through the basics, and then, so that time frame is not adequate to provide a cornea surgery for that person. That's the reason. I think many of the other specialities too, retina also would never want to engage. But on the other hand, we have short-term courses for lasers, and both in retina, glaucoma, and other areas. But we definitely would not want to encourage a specialty which requires a little more time.
And as Dr. Usha mentioned, in a month's time, when a person comes and wants a surgery the next day without knowing anatomy, physiology, he doesn't know how to respect the sterilization, attitude, the way he handles the patient, that all play a part in the training. Initially in the morning somebody said, how can a trainee can do a surgery? The patient was not concerned about the way he does it, the way he talks, the way that makes a big difference. The trainee, if he's trained well, respects the patient and does the best from him, everybody will accept it. The way he talks sometimes collapses the patient. That shows his ignorance. So we have a long-term fellows. In fact, tell you, our long-term fellow does almost 40 to 50% of entire surgeries in our camp and free direct and paying. That they develop so much of confidence, but it will not be given as a routine. It will be given only when the candidate takes the initiative in learning the holistic aspect and committed to that surgery. If he has ruptured a PC, he has to be there. If he has produced an iritis, he should sleep with the patient. That should be the attitude.
I had realized, I'm not an ophthalmologist, I'm not a doctor. With Dr. Nachar, when ROLAB set up from Sight Savers, we had a collaborative program called She is to Train. 2 months Aravind Sight Savers microsurgery training. So they come and learn, and then by the time they leave, they would have done close to 100 surgeries portion of it assisted and portion of it unassisted, etc. That's the type A capsule. I used to get requests for recommending to that course. I always used to tell them, you apply because the guru has to decide whom she will teach and I will not interfere. Believe me, I have received letters from the Director General of Armed Forces Medical Services that I want to undergo that because in my days I did not use microsurgery. But he was the Dean of AFMC and then this thing. And so the position doesn't matter. We had a later 4 months courses for the trainer of trainers thing. So a lot of professors and they came and their work system and discipline, not only here in LV Prasad also I've seen. So there is a period of method and cultural adjustment before they can trust a patient. So there will be people on different points of the knowledge experience curve. Designation comes out of time spent in the organization. That comes out of how much of the time has been spent in actually doing things.
Madam, what's the ratio of male and female in MLOP cadre?
Can't you see? All madams are here. She will tell.
MLOPs, we only have one male refractionist in the entire organization.
87% are girls here.
Yeah.
The whole Aravind is 87% are women.
The rationale, I don't think
I think Tulasi and few Krishna, like that we have 10%.
No, the rationale, I don't think you'll be very
because
happy
it is Madurai. Meenakshi is the queen.
No,
The rationale, you have to tell the truth.
Yeah, I think I'm going to run away after this. But then we found out that we've had a few males also who were trained, but we found out that the loyalty, the commitment, and the patience. When I mean the patience in the sense handling people and all the patients, it's a little more in the women. So and the one other aspect also, see, women generally try to stick on to a particular job. Not that it doesn't happen, the job hopping doesn't happen amongst the women, but people tend to look at the security and safety aspects, the organization where they work, and they don't keep job hunting like the men do. This is out of our experience I'm talking. I'm not trying to generalize it, but this has been our experience. One main thing is the loyalty factor, the commitment, and nursing as such is more associated with women. I think it's my, I don't know, madam also would agree to it. So I think that job suits better for women.
I'll share a small personal experience. There is a hospital at Amethi called Indira Gandhi Eye Hospital. All the girls from Amethi were brought here, put through the same training. Usha went and selected them. And after training, they have been posted there. They are girls from UP. Came here for 1 year. They were here and monitored, and then some senior MLOPs from here went there to be the local Akas, the elder sister, Didi is there and all that. So I went to Amethi to see how the hospital is running, and my method of assessing a hospital is talking to the patients, not this. We asked the girl who was going with a paper somewhere, the MLOP, so this tested where is to be done. Then she got hold of the patient's hand, took to that place, told the testing person these are the tests to be done. After this person has to go to so-and-so doctor for along with the test outcome, etc. Then she went on her work. He said in UP, whichever hospital I gone, if I had asked for, they would have either walked past or they would have said like this, or they would say, I don't know. And this was a different experience to me. Look at that patient's judgment of a hospital was not on the clinical skills or the equipment or the qualification or anything. How he or his patient has been dealt with by an MLOP. She's a window. And we have to recognize that that's the contribution they can make if we give them the opportunity.
So one
Yes,
more
sir.
point to add why women we have selected is, the men have lot of distractions, that age group, 20, 25, and it's hard for them to sit in one place. So the education part and healthcare, the women have definitely a better role because their judgment, their common sense, their dedication is much stronger in every aspect than men. Certain jobs where we are not very good. So strongly I feel the healthcare, I think women should really dominate right now. I mean, it
Madam,
should.
in
Because
the
it's like
morning,
kindergarten children, you know, the girl teachers are more like with students than thing. But in engineering thing, we are not, you know, the men are quite capable. They're very strong in that field. So feel like healthcare should attract women more.
Madam, in the morning, Dr. Junaid told that the collection was 1,000 when a male was posted there, and it became 4,000 the day female came.
See, I think that's the best example, isn't it?
Yes, in response to Dr.
You have to hold the mic, sir.
Yeah. Dr. Krishnadas' presentation, getting best out of the people. So we can discuss that thing in details. The best out, to get best out of the people, is it only the training that we get, or the infrastructure along with the instruments and the accessories for the surgeries that we also get? Because in private sector, yesterday in the hospital visit, I saw in the OT that you are using all the high-end operating microscopes for the cataract surgeries, wherein RIOs and more or less all government sector hospitals and medical colleges, we are having most of the basic model or even less than a basic model microscope, and a few, one or two high model microscope only reserved for the retina surgery. One thing. Second is, we are using the viscomet, that is the 100 rupees cost. And I think here you are using something like 1,500 or 2,000, or that visco Orolab, but there are different types of viscomet that everyone knows that something is reserved for some problem arises, then we can use it. But in government sector, we don't have such scopes. Number 3 is that lenses. We are all using the supplied lenses from the NPCB. But you have got the option for using different types of recent modalities lenses, including the Alcons, and also yours own. And the 4th one is the phaco machines. We are all having phaco machines, but that is also scarcity is there. Because previously it was in the RIO for 3 surgeons there was only 1 phaco machine. So you can easily understand the situation. And 1 phaco machine, if it goes wrong, then the whole day's phaco surgeries are off. And the last is the total infrastructure along with the AC. Because in this weather, that is hot and cold, especially in hot climatic weather, you will realize that to have best of the output, we need some these modern amenities, both for the doctors and for the patients also. So all these things I think should count the performances in the government hospital. Actually, the government hospital doctors are being marked that they are working in the government hospital. They are doing such and such. Madam was telling that he has learned that one professor is doing 1 surgery in a month. I don't know whether in reality there is a possibility of this thing. But all these hurdles are there. So if we want to increase our quality and also the bulk of the output, then we have to think also in these things. Thank you.
I will request Krishnadas to respond to a portion, but the entire session of Dr. Junaid was, whatever you said were the limitations, how we transcended it.
No, actually all our model is interrelated. Best, at the time also I told you something, but in this thing, getting best out of the people. So getting best out of the people is...
Absolutely zero disagreement. You're 100% right. I think it's very fundamental. I think to get the best out of the people, I think one, I would say the person must know what is expected of them. There's a clarity of function, what they're supposed to do. As a person being told exactly what is required. So that's, and oftentimes that is not that clear. Okay. Second is 100% without the tools they can't perform. You can't expect a doctor to perform without patients or without microscope or without, so what technology or that to me is kind of a local decision. But then if it's a microscope, it should be a functioning microscope. It should be adequate for doing whatever work they're supposed to be doing. You don't always need a Rolls Royce, okay? That may be individual decision of different institutions, okay? But then they must have something that is appropriate and adequate for the task they're expected to perform. Zero disagreement. And I think what we have to now recognize is that these things cannot happen by magic. These things cannot happen by a government dikat. No, so they will make the things available. So it's a local leadership. Like you are now a HOD of a department. It is up to you to create that environment for your staff. Or if you're director of RIO, it is up to you to somehow fight, do whatever you have to, no, or get some donations like Dr. Junayat has done, no, to create that environment for your staff. That is absolutely there. So obviously in our setup, we are kind of the management is organized to make sure that the staff is getting whatever they is required to do the task. Yeah, certainly. I think what you actually articulated quite well. Yeah.
That is answered most.
But sir, I disagree with one point that there are professors who are doing just one surgery. That could be exceptional case.
Could be. I mean, I don't know where the data came from.
That data is absolutely exceptional. Rather, residents are after the life of the professor that you, sir, give some surgery to us. You are doing all the surgeries yourself.
Where did you go around 1 o'clock night? You asked somebody that where he went around 1 o'clock in the night? Accident. You were mentioning about an incident, sir. The Burns accident you were telling about. No?
Oh, I was in Vizag. I was in
the same statement cannot be given to a government doctor or a government employee. You know that?
What?
The same statement cannot be said to another person in the government because most of the time what happens is this political interference. Immediately you'll go to a local councillor or local MLA or sometimes even the minister. So immediately he says,
I was in government, sir.
No, at that time you have not been in government.
I was in government. I was in the Indian Railways.
But it need not necessarily be the same in other incidents, sir.
Huh?
Yeah.
Very strong. Not strong union. Unionism of labor started with Indian Railways. Mr. V.V. Giri, who later became president, started trade unionism in railways and then it spread to other industries.
No, the same thing doesn't happen in all other incidents, sir. Mostly they have political support. Immediately they go to a local person, local MLA or a councillor or a minister sometimes. Even minister, the minister can be approached at the lower level.
They will not go to 1 o'clock to the minister.
Not 1 o'clock, sir. After your statement, you will go to the minister.
Let him go. Let him go. It doesn't matter.
Can I just
that's what I'm saying. No, what I'm trying to respond to you is, there was an incident and there was a response from the person who is in charge of that unit for that incident by visiting the hospital, finding out from the doctors what needs to be done, arranging for blood or whatever, etc. It was a railway facility, so I was an officer, so I could make sure, because he was a Kalasi, was a class 4 employee, he doesn't get neglected. All those details I attended to. One is, there is an incident and support given. I can give you many examples like that, which I don't want to dwell on what I had done. But the thing is that makes a lot of difference to the employee and to the employees. It was not an isolated incident. I have been doing like that for the 5 years or 6 years I was there. When somebody's wife, this guy had gone out to attend to an accident site, his wife had labor pain. I took her in my jeep and got her admitted to the theatre. It has been built over a period. All that I'm saying is,
the union gets power over you when the employee and employee sees their concern for them is higher than yours.
Yes, sir.
That's all. Even after that, if it happens, it happens.
Now, another basic difference between the government employees and the NGO employees is that
I was a government employee in the example I gave.
I'm saying, I'm telling about different one. The NGO employee has got not the equal security what the government employee is enjoying. So even if he commits a mistake, but he is not likely to be sacked. Whereas Madam said she is prepared to sacrifice somebody who is found to be guilty. You are sacrificing. That doesn't happen in a government setup. That's the basic difference between the two. You'll come back with greater power and you will feel get ashamed rather.
Again, I'm saying I have sacked 14 employees in my career, sir, in the railway. One second.
Those days, not now.
One second. No, it's not very long back. I'm not that old. I may look so. But I have given employment to 2,000 people. So the reputation is, if I sack somebody, it must have been an extreme case. There are times when the MP has refused to take the case up. But don't go by my example or this thing I'm saying. All that I'm saying is, it has to be in you. I understand the limitations, I understand the difficulties, I understand all that, etc. You may not be able to do all that, but certainly you can do some. Certainly you can know all the employees' names. Certainly you can know all the employees' family condition. Certainly you know that whose son is studying well and whose son is going for some education and try and get some help. All those are possible. Exactly. Yeah, I agree.
3 years back, one of the government hospitals, there were 40 endophthalmitis in 1 week. In a similar private institution, there were 4 endophthalmitis. The action was towards that private, almost killed everyone mentally, physically. But the 40 case of the government just went peacefully. So how do the others feel? So both the parties have got a thing. If it is anything bad in a government institution, doesn't come up very quickly outside. But Trichy incident, we had a beautiful institution, very good leader, doing a large volume, sincere people. Unfortunately, this happened. You know, still case is going on, still the chief medical officer has to go to the court every day. Same thing happened in a government, same period, government institution, 40 people lost their eyesight. Nothing happened.
Sir, all that is being done either at Aravind or at other places or NGOs cannot be done in government. But all that is being done, also some of what is being done can certainly be done in government. And I personally, I respect L.P. Agarwal or Siva Reddy or all those people. In a government environment, the person from Sarojini Devi will vouch for me. Walk into Sarojini Devi, every place there is plaques of this is given by Lions Club, this is given by Rotary Club, this is given by this is given by that. He has found a mechanism of being able to take public philanthropy into a government institution. All of you may not have been able to get access of that. Some of you would be in different degrees. Could be able to generate. And then when the public gives the donation, they also would look for accountability and return of what has been given, how well it's being utilized. Suppose they give a vehicle for the patient and it is bringing vegetables for the chief medical officer. Naturally, you will not get a second vehicle. So I'm not saying that's being done. All that I'm saying is that is a type of gap. So the contact, I was telling her, the contact and compassion gives you the first donation. The credibility is the one which sustains a donor and enlarges the donor base. But then the mechanism of absorbing the donation you have to do.
There is no dearth of donors, sir.
Pardon?
There is no dearth of donors. Only there is dearth of shortcoming in the takers.
Tulsi, will you repeat the statement I always make? Huh? There is more money waiting for good work than good work waiting for money. I have seen it over the last 25 years. We are not, why Madam said, if a budget allocation is 300 crores, The state governments have been given 100 or 120 crores. They have not been able to get accountability of utilization of that. The 180 crores don't go. I had that experience. I left government and I went into this thing. And in a different context about education for the visually impaired, I went to the education secretary who happened to be my friend's friend. I went and asked him, what is this? You are giving only allocation of some 20 lakhs or so for education of visually impaired. You know how many children are blind and how many schools are there. And I gave him a big lecture. He sat and listened and laughed. Mr. Nagarajan, have a cup of tea, he said, and have some biscuit. He said, I have a budget of 20 lakhs, but there has been a demand for only 5 lakhs and accounting for only 3 lakhs of utilization. And in the government method of budgeting, they will look at what was spent last year, add 10% and give. So next year you will not even go into 20 lakhs, you are asking for 5 crores. So ask your guys to make use of the funds. But making of use of the funds is a pain because you have to fulfill this, fulfill, fine. So people don't do that. So they ask for more allocation. More allocation doesn't translate into money coming to the projects. Same is here. There is more money lapsing in every. Bihar used to be kept on being quoted that so much is allocated, it's not been utilized for whatever, etc. So money will come, sir. Let me put it slightly differently. There are obstacles in working in the government sector, but in between the obstacles are the windows of opportunity. You look at the obstacle or look at the windows to navigate your organization. You to see. All cannot be accomplished, but status quo would only mean deterioration. Yeah.
I have got an experience recently. That's why I was looking for a personal scope. Personal scope from madam. Today I am representing, from yesterday I am representing Arayo Kolkata. But presently I have been posted in another one institution, that is new medical college coming up in Calcutta as head of the department there. So it was a state general hospital of 130 beds. It hasn't got any eye OPD separate. It is sharing with ENT OPD 3 days a week. It myself and there is one RMO cum clinical tutor, what you call senior residents here. There is no refractionist, no microscope, not even the OPD minimum requirements are there. So I have asked our principal several times for this minimum things for seeing the patients and making the cataract surgeries arrangement. Also our ADHS ophthalmology and state program officer is sitting in front of me. I had lots of discussion with him also. I talked to director RIO also, and he told me and suggested me directly to approach madam when you have got the scope. That's why I am telling that it is not that amount that is available for immediate use, but it is the system that is making the hindrance. For last 3 months, I am sitting idle. There is no students, only the first year students has come up to second year, that they are going to complete the second year. So I don't have any students, I don't have any hospital job even, and they are putting a professor there, idle sitting. This is the condition. That's why I was talking to madam and I talked all these problems and directly asked for help.
That's why we called it right persons for the right job, sir. Evidently, that's addressed to the madam, not to you.
Excuse me, sir.
I agree. No, I've had that. I went and trained for diesel engine design. A friend of mine went and trained for diesel engine maintenance. I was posted in maintenance. He was posted in design. But
yesterday I was talking about the transfer policy of the RIO. I was involved with the setting up the pediatric ophthalmology in collaboration with the Orbis. And it is the second institution in India.
I know about it. I know about it.
Having the pediatric ophthalmology, and I was involved 100% with that thing. Just before completion of that project, I had been transferred to some other institution. This is the fact.
Excuse me, sir.
A different aspect about this. the services rendered by these MLOPs. Suppose nowadays there is a lot of activism in consumer, this medical fraternity has been brought under it. Suppose a consumer case occurs, the services rendered by these MLOPs will be taken as valid or deficiency in service.
Because these MLOPs are trained MLOPs and we have a local...
There's a difference between trained person and a qualified person. Because legal person sees a qualified, services to be rendered by qualified persons. Trained person may not be a qualified person. That's why I wanted to know.
No, for our 35 years of experience, we don't have any, we have lots of consumers, but not from MLOP level. But you also must remember, the other nursing staff, so-called BSA nursing, are not at all trained in eye. So you want a qualification or you want a skill. So in our case, the provided the training part, why I'm saying is, if you don't train and hire a person who is just white saree and white blouse, then your consumers will have a thing. Your consciousness, the person should be trained well, then qualified well in an institution. So we, in our thing, we have only 10 people are the so-called BSc nurses for the entire, take care of the ICU and all those things. The rest of them, all our +2 girls, but trained, our training is very, very efficient. I'm repeatedly saying it, the training, our girls are going and giving training to other institution registered nurses in Eyecare. Why they want the government institution are asking our MLOPs to come and help them.
You are getting accreditation also.
So it's a training that matters. So far we have never had a problem.
To what Madam said, we are delegating certain specific tasks to MLOPs, but under supervision, number one, and the care that is being provided, the service that is being provided to the patients is the sole responsibility of the concerned ophthalmologist. An MLOP will perform refraction, but the responsibility of giving the correct prescription to the patient still rests with the ophthalmologist. Yes.
I think your point is, can I just?
Okay.
Your point is, if something is legally defined and if it is being done by somebody else, what is the level of accountability? The question I think you'll have to see in terms of your standard operating procedures is, what aspects have to be personally done by them? What aspects are legally the responsibility of individuals? So I think that those details you'll have to go into, number one. As has been clarified, the responsibility legally is still that of the ophthalmologist. He takes a responsibility. Like a contractor, he may get the work done through a subcontractor, but the legal responsibility is that of the contractor. So similarly, I think we'll have to see, the point I think is being made is, if under, you see, I don't find any particular logic if I look at a dental technician, just to give some equipment to a dental surgeon. You don't need a very highly skilled person, I mean highly qualified person. If he is trained to do it in time, that should be adequate. I think some of those procedures also need to be looked at by the national level institution, but the legal responsibility is still that of the person. But if you still have very clearly defined standard operating procedures in terms of protocols, you have to be very, very watchful. That's where is the issue.
Yes, sir. Allahabad and then.
Can I tell you a joke?
Yeah, please, sir. It's timely.
There was a case in the court of law. The woman went and said that the day my husband's operation has been done in your eye hospital, he has lost interest in sex. The doctor said, we have just corrected his eyesight and we have not done anything there. So these problems keep on occurring. In the court of law, the degree is important, not the skill. What I mean to say is, at times there would be some problems. Like in UP, what is happening is that they come and the CMO has been given power to come to the clinic and check whether you have a registered optometrist trained. Whether he knows it is or not is a different aspect. But he should be registered, like MBBS registration, There are MCI registration also for ophthalmic surgeons also, whether they are properly looked after or not. All those things are being looked after these days. So this problem might crop up someday.
It will, it will. So you have to get accreditation to your people, one, or you have accredited people on roll for showing and people who are skilled for doing and blend it. So signature should be of the accredited person, doing should be of the thing. It could be that. Bangladesh did it because Bangladesh is very strong. They were against this thing. A lot of sidestepping had to be done. Yes, sir, yours.
So it's a curious responsibility of the surgeon to train the ophthalmic assistants from whom he is taking work. He cannot deny it, he can not decline from the responsibility. This stands true for the eye surgeons also. They are having DOMS and MS degree, but they are not operating. As madam said, non-operating surgeons. We all face such a number in government setup. Probably in Madurai, all consultants are operating. Catech and other things also. But in government, we may not have that number. We have 60 eye surgeons. 20 are operating, 40 are not operating. You can bring a horse to the water, but you cannot make him drink it. So I suggest here, and what I am planning to do in our state, we shall take work from those ophthalmic surgeons who are not operating for cataract or other things, to do work for diabetic retinopathy, glaucoma, cornea, pediatric ophthalmology and other blinding diseases which are in a large number now. This is the time that we should focus upon cataract, simultaneously address the problem of other non-curable blind. I recognize this thing recently that non-curable blind is a much feared of section. Otherwise, we may become USA or other developing countries where the blindness is of non-curable type. Here in India, we have the curable blindness due to cataract. So if we keep on focusing on cataract only, we cannot conquer the blindness completely. So what about this good number which is going into blindness day by day if we keep them allay? So these other eye specialists who are not operating can be taken for other eye diseases. That is my suggestion, and the house might think over it.
Ophthalmologist. But I don't think they will accept it because they don't want to do for any other reason.
Like that, one surgeon, he does not operate. When he says, I don't know, sir. So we sent him for training. Then he said, we could not get enough number of operations, so I am still afraid, I am not confident. There is one group which operates in private, not in government. There is one group.
What do you call them then?
The other group, they operate in hospital only, but they don't want to go out, ladies particularly. Because going out is a tedious thing. They have to come in the night back. We have IL surgery and 20 surgeons. So we are trying to engage them in other things.
There are another one possibilities are there. If in a unit, number of surgeons are 5 or 6, including the...
I thought Bengalis were fond of Mike. I find you are not.
Actually my voice doesn't require...
Okay, okay.
When we are having a unit of 5 or 6, including faculties and postgraduate trainees. So if there are number of cases 7, 8, 10, so the juniors, we have to offer it to the juniors also as they are doing a lot of jobs, and if they are not being trained, as everything is the future depends upon it. So sometimes we have to sacrifice our case to be done by them. This is also another one possibility. That why the seniors are not doing the surgeries and the juniors.
I will do it on a one-to-one with you because I don't fully, we'll talk about it. Your sir, and after that, madam. Him.
As and when a person joins,
Last two questions, okay?
joins post-graduation, nobody is one who wants to become a non-operating surgeon. That's very important. Once a person takes up ophthalmology, he'll like to operate. It is only either during the training or more so after the training that he feels the setbacks, meets the situation where he cannot operate, and eye surgery is one where if you see, if you don't do it for a long time, it's very difficult to get back your confidence. It's a period, if you don't operate for 2 years, 3 years or 4 years, you may develop a phobia or a sort of thing that you cannot do it. So it is not at the beginning. Anybody who has taken ophthalmology would love to operate. He'll never like to be labeled as a non-operating surgeon. So there is something in the system, and those have to be identified. Like if somebody is posted in a place where there is no operating microscope, nothing is there.
Very well said.
Over a period of time, he'll become non-operating surgeon.
Training and tools of trade have to go together.
Yes. So it's very important to initially give an opportunity, just after MS, that everybody should get a hands on. Later on, it may not be possible.
Thank you, sir. Madam, your last comment.
I want to emphasize on two things. We see a lot of doctors who qualify themselves in a private institute where they are not exposed to either clinical material or surgical material. Whatever they said and done, they will not be able to pick up certain points. Another thing is, as when we train some trainees, whatever they try the maximum, they just can't get the skill to do the surgery. We even point out the finer points where they go wrong, they are not able to pick up, and they'll never become good surgeons. So such people can switch over to medical ophthalmology and be safe, the patients are safe in their hands.
Thank you, madam. Ultimately, I'll close the discussion here. We can talk later. Ultimately, I don't know, this is my favorite statement. It is not the building, it is not the equipment, it is not the designation which produces, it is the people who produce service. So we should be patient-centric and we should be people-centric or employee-centric in making the organization click. Thank you very much for a lively discussion.